and the hard copy. And I think that that's the last of the housekeeping bit. So again, my name is Holly Wilcher, and I'm with the Infant Toddler Specialist Network at the State Capacity Building Center, and I represent Region 4, all those states down there in the southeast. And we're so glad to have you here today to spend the next hour with you discussing state strategies for building the supply of your infant toddler quality care. And we know that research and data tells us that the babies and toddlers we know out there and their families, that the majority of the care out there is average to poor. And so we are really excited about all of the efforts and strategies that states and territories are employing to change those numbers and flip them on their head altogether. And we are delighted to have Rene Williams here on the webinar today. And if you haven't met Rene from Maryland, you need to pretty soon, because she's on fire for promising practices and innovation in making sure that infants and toddlers and their families have continuity of care and access to quality care. And so I cannot wait for you to hear her story and just a little bit about what she's doing in Maryland to make sure that babies and families have awesome early care and learning experiences. So before we get started, just another reminder, if you can mute your phones, we're going to start recording the webinar, and we're also glad you're here. If you have any technical needs, please feel free to use the chat room, and you can chat them in there, and everyone can see them. So if you have questions for your peers too, that's great. And here's how we're going to be spending the next little bit together. We are going to start off by identifying ways that you use data to determine what kind of supply do you have in your state and territory, and where are your shortages with babies and care for babies and toddlers. We're going to examine some of your state supply building strategies and some state supply building strategies that are recommended by best practice. And then Rene is going to spend some time with us telling us her story in Maryland. And we just love state stories, and we love to hear how it works. So I know that you're going to benefit from hearing her story here today. And then we're going to transition into, we can't do any of this right without checking and making sure that what we're doing, we know what works well about what we're trying and what we might want to tweak in that continuous quality improvement process. So we're going to look at some resources and state strategies for how to measure our progress towards our supply building. Let's see if we're doing it well. And then this webinar is chock full of resources and references. And we're not going to go through all of those, because you can go through that on your own. We're going to spend most of our time discussing with you and Rene, her example in Maryland. But we're going to make sure that we reference those for you so you know where to find them later on the webinar. So when you do some follow-up or exploring some strategies, you can access those via the webinar. So just another reminder to mute your phones if you haven't done that already, and encouragement to use the chat box, and we'll go ahead and get started. So I'm not going to repeat these, but here are your learning objectives as a result of spending our next hour together. We hope that you're able to do these things listed on this slide here. And before we move into the state strategies portion and looking at our data to inform our decision making, I just wanted to focus on this slide for a little bit, because we believe that it really does set the tone for why we are focusing on this topic in general. And when the Child Care Development Block Grant was reauthorized, Congress added some new purposes, right, we know, to this act. And that the act includes a couple more provisions related to specifically building the supply of not just care, but quality care. And so right here you'll see where we're going to focus, where this red arrow is, because the act increased the share of funds that you as lead agencies are required to spend on quality activities, increasing that minimum that was previously a 4% requirement to 9% over 5 years. And moreover, authorizing that at least 3%, right, be designated specifically to improving quality care for babies and toddlers. So that is a significant kind of direction and our call to action here for why we can focus on specifically these supply building strategies that are effective for not just children birth through school age, but specifically infants and toddlers. That paired with the data that we know that the care that they're in right now is at average, on average, poor to mediocre quality care. And two constructs that we just want to make sure we operationalize right before we begin in terms of what we're talking about when we say supply, right, and what we talk about when we say quality. And this first slide focuses on supply. So we really want to stress that the issue of quality supply for infants and toddlers means not just that we have a quality rating and improvement system and that folks are participating in it, but it means that we have enough, right, enough slots to serve infants and toddlers, and that supply is spread out geographically so that it's available to families with infants and toddlers where they live, close to where they work, and also available at hours that services are needed by families, right, and that it's affordable and meets the standards of care. So that's a very loaded definition of supply, and we want to make sure that we're on the same page when we talk about supply. It's not just about the one-to-one correspondence, right? It's about all of those other factors as well. Next, the next construct that we want to make sure that we operationalize before we move forward so we're all on the same page is this construct of quality. And again, we could spend a series of 10 webinars, right, talking about quality, but we want to talk about quality in terms of the structural and process variables, right, and the measures and markers. And you all are familiar with quality rating and improvement systems or your state's quality frameworks that you have to measure quality. In addition, we have these awesome early Head Start standards, and we have the essential 6 essential practices for the program for infant toddler care. There are so many options for measuring quality in infant toddler care. And then we have these markers, right, that we're looking for. These our go-to true north markers for quality. Those adult-child interactions, that quality of environment. We want to make sure that when we talk about this construct of quality, that, again, it means enough supply, and that the quality is used by a measure that is widely recognized and accepted as best practice in infant toddler care. And we've looked at all the states, and y'all are doing amazing work in framing your quality approaches to measuring infant toddler care. So thanks for letting us set the stage really quickly for those two constructs. And before we make decisions about infant toddler supply building strategies, we have to ask ourselves certain questions, right, and to make data-informed decisions. And we want to identify what does our supply look like? Where are families with low incomes or who live in poverty who need these supplies and subsidies or vouchers? Where are CCDF providers located? And where is the quality? Where are the quality pockets and the gaps in quality for both providers who participate in Child Care Development Fund and those who don't? So, and finally, we also want to make sure that our data looks at where are the families? Where are their jobs? If there's a great pocket of quality but there are no families living there, then we make different decisions, right, based on that data. And then the next conversation that we have is about using that data to inform our decisions, right? And one of the things that we know is that some states have used different means to collect their data. And this is an example right here of New Jersey. They used a survey to examine the availability of their child care. And to understand the availability specifically of their center base, they conducted this questionnaire on the available slots that they had compared to the number of children likely to need care with all of the parents who are at work. So to get a frontline view New Jersey conducted a focus group, and they held it for directors and centers to discuss the challenges and supports needed to provide high-quality care for infants and toddlers. So this is just one strategy that a state used, and you can check out their report here, but we want to hear from you for a little bit, and we want to know how does your state gather information about the supply of infant toddler care in your area. So in just a second, you're going to see your screen change, and a poll is going to come up here for you. And we want you to tell us, you can check all of the options that are applied, but what are some of the ways that you make your data-informed decisions about your supply building strategies? And I thank you so much. I hope you can see the results populating. Looks like you all are engaging a lot of your child care partners. If there are ways that you collect data on the supply of your care, and they're not listed here, please do type them in the chat box so we can learn from each other, right? And then put your state in parentheses so we can know which state is employing that innovative strategy. So I'm just going to give you a couple more seconds to participate in this. I know Rene is going to talk a little bit later about how they established theirs, understanding about their slots. Okay, wow, a lot of you are collaborating with your child care resource and referral agencies, your partners who have their finger on the pulse and understanding. And then Maureen thinks you've got Child Care of Aware mapping project. Fantastic. Thanks so much for sharing. A lot of you use quality framework, your quality framework or your quality rating and improvement system. Well, everybody has selected one of the most usual suspect ways to collect data. So thanks for sharing that. I see the most popular, of course, is Child Care Resource and Referral, and then the quality framework seems to us. Thanks everybody for participating in that poll. That was really helpful data, and continue to chart those ideas of other ways you get your data in the chat box so we can all learn. So this slide just shows the myriad of choices that you all selected. You know, there's any number of creative ways, right, to get the information that we use to make decisions about what our supply is. And making those data-informed decisions is super important, because otherwise we're shooting a target in the dark, right, about what we need. The next thing that you may consider is how to determine that true cost of quality. And this slide just talks a little bit about some of the means to get that true cost of quality. So some of you have used the Provider Cost of Quality Calculator. It's a tool that's available to you. It's linked further down in this webinar slide, presentation. And you can estimate the true cost of quality for how much you want to reimburse your infant toddler providers versus your preschool, et cetera, and then all of the factors that you can think about in helping a program to determine the true cost of quality. You can also get provider rates from subsidy programs, looking at, you know, average wage and families' ability to pay. And what we know is that it's comparing that actual cost of the ability to gain subsidies, parent fees, and other sources of funding, factor into, you know, the real picture of kind of our gaps between quality and the cost. So there's tons of factors that we want to consider in those cost of quality. And we know, right, that one of the highest costs is that personnel cost, and that's a huge driver of the child care budget, specifically in those infant toddler rooms. So that cost of quality calculator can help you out with that too. And if you have other ways that you determine the cost of quality in your states, we'd love to hear about it in the chat room. So please do. Or if you've got an experience with the calculator and you've used it, please do share it with your peers in the chat room. So the next slide, we've just summarized kind of making those data-driven informed decisions and making sure that we've got the cost of quality, and we've got some state and national resources further down linked in the PowerPoint where you can look at how states have used the cost of quality and reports on that. So be sure to check those out after you've downloaded the webinar. And the next little bit we're going to jump in is looking at strategies, right, to build the supply of high-quality infant toddler care. And so right here you've got a bunch of kind of official lists of kind of ideas that have been generated from an information memorandum that came out right after the reauthorization of the Childcare Development Block Act. And these strategies were identified as kind of these lowest hanging fruits, right, the ones that we employ most often. But we want to hear from you again. We want to hear which one of these speak to you and are your states using to increase the supply of quality. So in just a second, you're going to see your screen change again, and we want to poll you and have you tell us, please check all that apply. What are the following strategies that you're using to increase the supply of your infant toddler quality care in your state? I'm just going to give you a couple seconds. And once again, if you don't see the innovative or promising practice strategy that you're using, please do talk about it in the chat with your peers so we can learn from you. Or if you're not sure what your state is providing, feel free to say that too in the chat box. So thank you. That's awesome. A lot of you are using the Early Head Start Childcare Partnership model, and very exciting. We're getting that preliminary data on the efficacy of partnerships and collaborations and what those mean for children and families. Very exciting. Many of you are engaging in the technical assistance and business practices. Awesome. Building the capacity of those programs to sustain the business aspect of it. Essential. Not seeing it. Oh, thank you, Kathy. I'm going to check the little broadcast results little box on here so you can see that. Hopefully you can see it now. Some of you are using Community Hub. Some of you are using financial incentives, but by and large, ongoing technical assistance and support is a huge practice and an evidence-based one, right? It's helping our programs improve their quality and sustain and stay in business, right? Thank you so much for taking some time to share with us those strategies. We know that your Child Care Development Fund administrators discuss them in your child care development plans that are publicly available, but it's always good to kind of see theory to practice there and what's happening. So we appreciate you sharing your responses here and selecting all that apply. And then please do, if you want to talk about something that you're really excited about that your state is doing, please chat it in the chat room. That would be great. Okay, you're going to see your screen change in just a little bit again, and we'll get back to the PowerPoint. So in this next slide here, you're going to see about we know we have the strategies, right? And then with that, we want to couple the financing practices with it. And so this slide talks about some of the financing strategies that we can use to really bring those approaches to life for increasing the supply. And here are your usual, lowest hanging fruits here. We would be remiss to not mention that 3% that we want to make sure we allocate and dedicate to the infant toddler portion of quality improvement. And then some states are using capital financing, grants and loans. We have lots of examples of that and some reports listed later on this slide. Subsidy rate setting. This is interesting. For example, Delaware found that, at least it's not practicing now, they did in the past, found that through a cost modeling that its reimbursement rate for infant toddler care was actually not sufficient to attract providers. And so they made adjustments accordingly so that they could make sure that reimbursement rate matched the true cost of quality so that an infant toddler care provider could stay in business. We know tax incentives and credits, incentives to convert infants and toddlers in infant toddler classes, that layering and braiding of funding. We've learned a lot about that through the partnerships grant, right? And then in Maryland and Minnesota, for example, have required or have given points, at least at one time, for child and adult care food participation in their quality rating and improvement system. So some examples there of how 2 states have layered in braided funding that's available for just participating in quality activities, right? And then this is one of the examples of a strategy to improve the quality and supply, and you can see from Arizona and Georgia 2 non-early Head Start Childcare Partnership, public-private partnerships examples here. I know we focus a lot on the early Head Start Childcare Partnerships, and there's a lot of other partnerships as well that can increase the supply and quality. And you see here Georgia has a Talk With Me Baby. That's a cross-sector professional development for health nutrition that's advancing the professional workforce development there. And they partner with health and education, higher education, and the state. So they've engaged all of their partners in Georgia at that level with this professional development initiative. And then in Arizona, the First Things First, you can see here that these local councils are allocated with state dollars to provide this family-friendly, comprehensive, collaborative, kind of early childhood comprehensive systems approach to development and health for Arizona's children. So all kinds of public-private partnerships, and these are just 2, though. Some more listed later on in the webinar. And then another strategy is the use of hubs, and please know that this is not exhaustive by any means. If we listed all the examples, we would be not going on for 3 hours here. But hubs are a model established privately or by that government to provide a variety of supports to child care providers. And some hubs are used as a center to associate family child care centers with, and others are a cluster of smaller centers with high quality center as a hub, and they provide a variety of early childhood services. But it's a way to streamline and create efficiencies and economies of scale for business, for child care businesses. And here are 2 examples here in Maryland and in Oregon. And then a couple more strategies before we launch into hearing from Rene on the business aspect. Let's see, we've got one of the really promising practice that we're getting some emerging data on, and a lot of people are jumping into, is the practice of implementing staffed family child care networks. And these are more than just kind of associations of family child care providers and where they network together. This is a full-time, with at least one full-time equivalent of a person who is working to support the quality improvement of family child care. We know that families with babies and toddlers often prefer family child care, right, as a setting for their early care for their infants. And so here are 3 examples in 3 states. Connecticut has a local example in New Haven of All Our Kin, and you can see they provide a variety of the strategies that improve the quality of infant toddler care, as well as training and networking and lending libraries and accreditation support and all kinds. And then Massachusetts has one that's specifically dedicated to supporting women in business. And so that's kind of the lens on the Acre Family Child Care's mission. And then finally, in Virginia, the Infant Toddler Family Daycare is a private nonprofit, and they are licensed to recruit and screen, licensed by the Commonwealth, recruit and screen family child care providers and help them with their credentials and also the ongoing kind of business development supports that they might need, and resource and referral services, and connecting those families with the care. So from the business aspect to supporting and connecting the families with the care, there are lots of different models of staff family child care, and there's a resource later on in the webinar in the slides on a new technical assistance manual that's come out from the Quality Center, and on how to start and implement and evaluate effectively infant toddler or staffed family child care networks. And there's also a cost estimation model that's linked there, and then just a brief on kind of the research around the staffed family child care network. So that's one of the strategies for increasing quality of family child care that's gaining a lot of attention lately. So I think we are going to head into, see if Rene is on. Rene, are you on?
Yes, I am.
Awesome. Okay, just checking to make sure you're there. The last strategy that we're going to talk to before we transition into Rene is the use of grants and contracts to increase the supply. And there are currently 43 states, 43 of you are using grants and contracts to enhance the supply. And this strategy is where the subsidy is received through this grant and contract instead of the traditional voucher following the child and the family. So some of you are employing these to see if it has an impact on the continuity of care, the sustainability of the provider, and you can see some data here in this slide on that practice, on which states are doing what. And of course, you know, some of this is happening in the early Head Start Childcare Partnership world, and some of it's happening outside. And there's a fantastic resource embedded in the PowerPoint later on kind of a comprehensive look at how to use grants and contracts, or how to start them up if you want to, and the states that are doing them and how they're using grants and contracts. So be sure to check that one out later. And I just listed one example here of Vermont. They have 15 parent-child centers that they use for grants and contracts that they offer support with a variety of services, not just of which is helping families find home care, find childcare, help families find childcare rather. They also provide home visiting, early intervention, referrals. So this is an example of Vermont using a state who is already providing a family-friendly service to provide as their grants and contracts hub, if you will, to marry both of those constructs. So, and at this time, I'm so glad you don't have to hear me talk for a while, because my new friend, Rene Williams, is going to talk to you. She is the Chief of Childcare Subsidy at the Maryland, as you can see on the slide, Maryland State Department of Education. And we got to talking, and she has a rich history in Region 4, where she started out in Alabama and has probably identified worked at every end of the spectrum of childcare, and especially related with subsidy, and knows our dear friends Calvin Moore and in Alabama, and some other friends we realized we connected on. But I reached out to Beverly Wellens in Region 3 and said, I would love for Rene to talk to our peers about what they're doing, and I'm really grateful to Beverly that she said, yes, that sounds great, and even more grateful to Rene. So Rene, I'm going to turn it over to you now, and I'd love for you to tell us the story about what you're doing in Maryland to centralize the subsidy system and make the care, an impact on the care for infants and toddlers and the quality in Maryland.
Thank you, Rene. Thank you, Ms. Wiltshire. On behalf of Ms. Beverly Wellens, Region 3 Program Manager, Ms. Elizabeth Kelly, Maryland CCDF Administrator, thank you, ICF, for this opportunity to share Maryland's decision to centralize, for highlighting research completed by Dr. Rebecca Medell on behalf of MSDE and Child Trends, and for exploring how the Child Trends data connects and impacts three of America's most precious resources, infants, toddlers, and their caregivers. The hardest slide for me to develop is this slide right here that has an overview of my work history and influence. Each dot on this slide represents a large part of who I am and what I hope to become. Today is day 481 in my current position. On days when the learning curve appears like Mount Everest, each dot on this page is a compass of hope and reminder of what I need to become in order to move forward on Team CCDF. Each dot represents people, places, and agencies in 22 years of work to support CCDF administration and regulations and case managers. Dot 604 represents the name given to the CCDF final rule. In taking the final rule home to read over a weekend, my first response was 604 pages. Who writes 604 pages? In reading 604, My life was profoundly changed because the 604 provided me with the whys behind the law. It connected my dots and enabled me to clearly see faces of infants and toddlers behind each decision made by CCDF administrators. The dot, child trends, connects my entire employment history. My initial employer, Childcare Resource Center, proposed to Alabama Department of Human Resources, let us demonstrate what happens when child care subsidy is determined by an agency that only authorizes child care subsidy and where the agency's single focus is early care and education. As a result of the CCRC pilot, a form of centralization called Child Care Management Agencies was born in Alabama. After supervising a child care management agency in Alabama for 13 years and managing 2 child care subsidy programs in Maryland for 4 years, I understand firsthand Maryland's decision to centralize, which begins on the next slide. Parents on our subsidy program work or attend educational training programs in Maryland, Pennsylvania, the Virginias, Delaware, and Washington, D.C. The red circles represent children and working parents that are the hands and souls of industries that provide food, clothing, safety, comfort to Marylanders and in some cases the world. They are valuable to society and as their child's first teacher. The red dots numbered 1 through 24 represent the local departments of social services located in Baltimore City and within the 23 counties that comprise Maryland. The blue dot represents CCS Central. CCS Central is a single vendor that contracts with MSDE to complete statewide provider payment, overpayment calculations, and child care authorizations. The white star represents the location of MSDE, the CCDF lead for Maryland. Details on the Maryland subsidy program continue on the next slide. The figurine represents MSDE. Maryland is currently serving over 10,000 children on the state subsidy program, and we have over 4,000 eligible children on our wait list. A family size of 4 submitting an initial application would be waitlisted with income slightly over $28,000. Although Maryland had the 3rd highest state median income in 2016, there is a high price tag associated with living in Maryland. For example, housing in Montgomery County is comparable to New York City, New York, and the average cost of infant care in the same county is $1,400 a month. So with Maryland's subsidy rate set at the 10th percentile of the market rate survey, access to higher quality child care is often not an option for parents eligible for child care subsidy. The next slide captures Maryland's decision to centralize. The figurine on the left represents MSDE. Our administrative oversight is limited based upon case managers being located in 23 counties and in multiple locations in Baltimore City. Case managers that manage multiple eligibility programs are employees of the Department of Human Services and who have direct supervisory and administrative leadership that have separate bottom lines, separate mission statements, separate eligibility focus and output, and they do not report to MSDE, the CCDF lead. The figurine on the right represents MSDE having administrative oversight over one vendor in one location who only authorizes child care subsidy and is financially penalized if monthly service level agreements related to authorization are not met. Surely, when Maryland made the decision to centralize, someone had to ask the question, what is less problematic to manage, 24 or 1 versus 24? Another paramount reason for centralization is on the next slide. Delinking. Maryland needed to delink, meaning to separate child care subsidy authorization from all other eligibility programs in order to increase continuity of care for children. This slide depicts what often happens at the case management level. The figurine on the left is a case manager who manages 4 eligibility programs. It's her lucky day because child care subsidy has just been added to her caseload. Although child care subsidy authorization is 12 months, the case manager decides to align child care vouchers for 6 months and will give the remaining 6 months at redetermination. Although this is a good case management strategy, it is a strategy that could result in child care being ended prematurely. Reauthorization allows CCS alignment with other redeterminations as long as the authorization is 12 months, or when aligning, the clock for CCS authorization is reset for 12 months. Another example of delinking is on the next slide. On this slide, the parent fails to comply with TANF requirements, so the case manager ends child care vouchers until the parent complies. In Maryland, case managers often manage multiple eligibility programs and use child care subsidy vouchers as a carrot to get parents to comply with other eligibility programs. Maryland's decision to centralize was based upon the need to totally delink child care subsidy authorization from all other eligibility programs in order to decrease the interruption or the delay of child care authorization. A final example of delinking is on the next slide. As Maryland continued to look at data, Maryland noticed voucher durations for 2 weeks, 4 weeks, or 2 months, often for the same child. As a result, the child revolved in and out of child care, Delinking child care subsidy eligibility from all other eligibility programs remains a very hard concept for case managers managing multiple eligibility programs. As Maryland continued to look at data, our goal to delink child care subsidy was to protect and promote the social-emotional development of children. Maryland's path to centralization is captured on the next slide. In October of 2015, with continuity of care being a major pillar of reauthorization, MSDE modified our computer system to have a soft default to 12 months. On August the 31st in 2015, Maryland fully centralized. Like renovating a 300-year-old house, you can plan, allocate, and align resources, but until you get behind the walls and down to the foundation, you cannot truly predict the cost of the unexpected. On December the 18th, 2015, Maryland had to modify full centralization to the model that is depicted on the figurine. The challenges with transitioning are on the next slide. Variation in policy interpretation and implementation. Maryland has one policy that governs the child care subsidy program. Upon full centralization, paraphrasing the Lowe's commercial which says, "I never knew there were so many different shades of blue," MSDE did not know the extent of the shades of policy interpretation and implementation until centralization occurred. Culture. Parents and providers had a hard time accepting work to drop off documents. Volume. Prior to the transition, total calls received by the local departments statewide were less than 6,000 per month. During the initial months of centralization, CS Central received over 40,000 calls per month. Program priorities. Once centralization was announced, child care subsidy authorization was no longer a priority for many case managers, so parents and providers were penalized. Computer system. Not having system roles modified or restricted at the point of the transition had a negative consequence on the transition. Human service versus automation. We underestimated the cries from parents not having a place to go that was very familiar to them. Another visual of the transition is on the next slide. Prior to August 31st, the 24 local departments issued CCS vouchers to TANF and non-TANF clients. From August the 31st through December the 18th, CCS Central issued vouchers for the entire state of Maryland. The figurine in the blue dress represents Maryland's current structure. As the stars on the figurine suggest, the bronze star goes to the figurine in the pink dress. The silver star goes to the figurine in the blue dress. This is a structure that is not ideal, but Maryland has greater control over 2/3 of the subsidy cases that are authorized on behalf of MSDE with this configuration. And the gold star goes to the figurine in the green dress once centralization has been given an opportunity to grow. Some of the benefits of centralization are on the next slide. Faster application processing. From all points of documentation received, CCS Central is currently processing applications in 7 days or less. Policy implementation and interpretation, assistance and checks and balances is always easier with fewer or one entity. Increased benefits to children. When applications are processed sooner, vouchers are issued sooner, and children access child care sooner. When continuity of care is increased, the child reaps the developmental benefits. The challenges with transitioning centralization are on the following slide.
Is good.
Please forward the slide.
Sorry, Renee. Thanks.
No problem. This slide demonstrates work that was completed by CCS Central in the months of June, July, and August. Data speaks volumes and tells CCDF administrators whether or not subsidy is being authorized in accordance with CCS regulations and the health and welfare of the program that's being administrated. Having the ability to access and review data is critical because the case manager is the drawbridge between the intent of reauthorization and the benefits of reauthorization reaching the child. What a case manager does or does not do and how they implement policy will determine if subsidy is authorized in a manner that promotes stability and continuity of care or impedes positive social emotional development of children. Lessons learned are on the final slide. Know the history of CCS in your state. Knowing the past will help identify potential allies and adversaries if your state is planning to make a transition similar to Maryland. Know the impact on providers. Providers are normally silent unless their payment is impacted. Do your best to make sure their payment is not impacted. Know components and barriers to the provision of seamless services. The closer centralization looks to the before picture, the easier the transition will be for parents and providers. No, everyone will not cheer your state's decision to centralize. If the slightest change is felt by most, Before making a decision as tremendous as the decision to centralize authorization, go ahead and buy stock in aprons because tomato throwers will be encountered. The squeaky wheel gets oil. Resolve matters when only a drop of oil is needed. Know your why when faced with difficulty. Maryland's decision to centralize was to increase continuity and stability of care for children by having greater controls at the case management level. Again, case managers are the drawbridge between the intent of reauthorization and the benefits of reauthorization reaching the child. Maryland's decision to centralize was to have better controls at the case management level. In conclusion, I hope Child Trends will be able to expand their research conducted in Maryland across all states and territories. I truly believe that the expansion of their research will let us know as CCF administrators whether or not the procedures we put in place to increase continuity of care for infants, toddlers, and children are taking hold. Thank you, ICF, for this opportunity to present. Thank you, Ms. Wilkes.
Thank you, Rene. Your story is just so, I have just such a visual of my head of these babies staying longer in their family's arms and in the caregiver's arms. And I think about the webinar that I heard you speak on with Child Trends when they were sharing the data, and you had me at continuity of care. And I just am really, really glad that you were on today for us. And we do have one question, and you may or may not know the answer to this, and that's okay. And I encourage others Rene got a lot of great questions as she's been doing this process and implementing this approach. And as she mentioned, Child Trends has been working closely with her to evaluate, which we're going to talk about in a little bit, the efficacy of this approach. Is it making a difference? But Rene, one of the questions that I want to ask you that Mandy has, and Mandy, I'm not sure where you're from, but you don't have to say that, but you put it in the chat. When you were delinking with the eligibility of the other programs, what implications does that have on your data sharing? Do they still have the data to share with you? Do you have data sharing agreements or MOUs, or what were the implications on that with sharing the data across those other programs? Do you know?
We still share data across other programs. Mm-hmm. And in reference to delinking, in reference to the 604, the final rule, one of the things that it talks about is that child care subsidy is delinked from the other programs. So we still work with all the other eligibility programs, but the main point in reference to delinking is that child care subsidy authorization, the policies and the procedures are separate from other regulations. So what was happening in Maryland and what continues to happen and what we continue to work on is that, for example, if a parent is authorized for child care subsidy, that means that they have met all points of eligibility. At the point of meeting all points of eligibility, that parent is eligible to receive a voucher for 12 months. But if a case manager is managing a TANF program, for example, and the worker stops, the parent stops participating in TANF, what the workers often do is they apply their TANF rules to child care subsidy, and they end the vouchers. So to answer your question, we have a memorandum of understanding with the Department of Human Services, which allows their workers to authorize vouchers on behalf of Maryland State Department of Education. We still share data, but what we have to delink is to get the workers to understand that they cannot change child care vouchers based on what's happening in the other program.
Excellent. I remember you saying, Rene, and it really hit me, the realization that your workforce, the professionals had when they realized that they could not just discontinue, the services, not services, but the voucher, and what a wake-up call that was, and that the eligibility, would continue on regardless of, the previous and the process that you went through of streamlining that and sending that message out and so that everyone was on the same page and there was one shade of blue.
Right. And so I just would like to add to that by saying we're still working on that process, and ICF is going to help us to get the message out. And as I stated in the beginning, not only was it a wake-up call at the case management level, it was a wake-up call for me. As I stated at the beginning of the presentation, when I sat and I actually read the 604, and I got to the point in the document where it talked about how children learn and what impact is made upon them when they are snatched in and out of childcare, and how children learn by being in stable environments, it made me say, wait a minute, all this time I have said I serve children, but in all actuality, I don't really know if I look beyond trying to pass the next audit or trying to make sure we didn't make any mistakes. I didn't understand the full impact of what it was that we were doing. So that 604 was a wake-up call for me. And yes, as Maryland continues to talk to case managers more, yes, they are in shock because, like for me, their focus for many years has been on the parent and not the child. And I think that that's just an overview of what the whole reauthorization is all about. It's about making sure that the funds and what we do promote the welfare of children.
Rene, that's just so beautifully stated, and what a revelation. And I'm sure that you've got about 58 childcare development state administrators kind of shaking their head here with you if we could see a video today. So we've got about 5 minutes left in our webinar. And I have also just want everyone to know linked the child trends research in this webinar with you later on. But I think that this is a great segue into the last section of our time together, which is just emphasizing that we can do all of this, but unless we kind of take a look at what's working and what's not working and what we might want to tweak to improve for not only that our checks and balances, but moreover for our families and children, which I really think is the reauthorization as well as best practice, right? That lightning bolt that you had, Rene, about learning that we really would be remiss. So we talked about all these strategies, and Rene highlighted what she's doing through what Maryland is doing in the centralization to create that continuity of care and eliminate the bouncing around of children and families and the deleterious impacts we know that has on their development, to make sure that they're staying with those warm and nurturing arms longer and in this quality care longer. We want to talk about how you measure progress. So as we're talking about a couple of examples, if you want to chat in the chat room, ways that you're in measuring the impact of your strategies for supply building, please share with us. Some of you might measure the progress by increasing the supply of quality care for infants and toddlers. Rene in Maryland has data on the continuity of care, of children in care. It's so exciting. And they're going to continue to have more data as the time goes on. And maybe you measure it by more infants and toddlers with lower incomes having quality of care. Maybe you measure it by the increase in the competent and qualified workforce, right? So there's a lot of different ways to measure. And here's one resource, a national resource. And I love this resource, and I know that my team will probably laugh at me because it's like any strategy that you have, if you want to develop, implement, and evaluate its efficacy, this resource right here, the Integrated Stage-Based Framework for Implementation, helps you from beginning to finish plug in any early childhood effort you have to make sure you've got that continuous quality improvement process embedded in your implementation. So it's linked right here. It's a brief by OPRE, and I call it a fail-safe way to evaluate any of your strategies. And then later on, I'm going to just scroll through a couple of these. You've got some other additional state examples and national resources for supply building. Here's a state strategy that Michigan used to help families access care. They did, what can Michigan do to help parents and children access quality care? They did a study and conducted shared some recommendations and findings there. Another state strategy, Nebraska looked what's our workforce looking like? Is it competent? And specifically for infants and toddlers. We've got just a ton of these. Planning and practices to consider, planning and policies to consider when implementing contracts and grants, which is another promising practice. CLASP has issued this, also another great national resource on to help states and guide states in their implementation of the best practices for building infant and toddler quality and supply of care. And I'm just going to scroll through a couple of these. There's a lot of other examples of states measuring their progress. There's a report out of New Haven, and we have a resource on the Infant Toddler Resource Guide, which we can link that in the chat box on a variety of other state and territory approaches to improving the quality and supply of infant toddler care. So there's 1 minute left, and I would be remiss not to thank all of you for being on today, and reminding you that there's a questionnaire linked in your chat box that allows you to tell us how about your experience today and what worked well, what you benefited from, and what could have been a little bit different for you to better meet your needs and your learning about how to increase the supply of infant toddler care. And we encourage you to look through the state examples and national resources found later on in this webinar, and also just want to bring your attention to the child trends data that's linked from Rene's research in Maryland with checking on how the centralization was implemented and how well it's working and what's their data on child and family outcomes from that. So thank you so much, Rene, for being on with us today and taking your time to share your story. I also want to thank Kelly Perkins and Ron Schaefer, for my infant toddler specialist colleagues, for helping me with the technical aspects. And I want to thank all of you who are working so hard to implement the reauthorization and implement these strategies to build the quality and supply of infant toddler care in your state and territory. We're glad to have you today and look forward to seeing you on the next topics webinar. And we wish you all well. Goodbye.